The chairperson can invite Dr. Pramod for the next panel discussion, which will be our last session.
So, ladies and gentlemen, I would like to introduce our dear friend, Dr. Pramod Garg, very eminent gastroenterologist, professor of gastroenterology at All India Institute of Medical Science. And he will be conducting a panel discussion on the pancreatic fluid collection. And I would like to invite our other panelists, Dr. Kenneth Binmoller. Sham, you can be around, and of course, we need your inputs. I would invite Professor Mark Giovannini, Anthony Teo from Hong Kong, and Vinay. I hope they all are online. Welcome you all. Congratulations to Rajesh for a fantastic meeting. Over to Dr. Pramod. Thank you.
Thank you, Vipul. Thank you, Rajesh, once again for giving this opportunity. I'm indeed very happy to have this panel discussion and having all these stalwarts with me who have actually done excellent work in this area, starting Ken Binmoller, who is inventor of Hot Axios, Sham, who has done excellent work. And Sham, thank you very much for an excellent talk. This has really set the stage for the panel discussion. I'm not sure if Mark Giovannini is here, but all of you know that he's an excellent endoscopist. Theo Anthony from Hong Kong, again, a star endoscopist, EUS person who has done excellent work. And last but not the least, Vinadhir, who has actually done a lot of work on pseudocyst and wall of necrosis, metal and plastic stents, and so on. So thank you all very much for joining this panel discussion. Many of the audience might be thinking that we are going to discuss a large vault of necrosis, put in a metal stent. Sham is here. In fact, all the experts here with me will put in a stent there and patient is all right. So you will be disappointed because this is just one part of the discussion that we're going to have today, okay? So I'll just briefly introduce the topic of acute pancreatitis so that people understand when we discuss about fluid collections, what is it that we are dealing with? A small subset of patients. So this is a 55-year-old lady, abdominal pain for a day, comes with SIRS parameters 2 out of 4, oxygen saturation 90% on 2 liters of oxygen. She has grade 2. Respiratory failure, ultrasound shows bulky pancreas, CT was not done, day 2. Diagnosis acute pancreatitis, creatinine day 3 was 2.4. So here is a classic case with severe acute pancreatitis, 2 organ dysfunction, hospitalized in ICU. Fortunately, 90% of patients have mild disease, and we're really not worried about them. They are the ones who are treated in primary or secondary care hospitals, and they do well. What we are worried about, the 10 to 20% who have moderately severe or severe disease. So the concerns here are organ dysfunction. Sham, you touched upon this issue. Let me ask you, how worried are you in the first week of illness when a patient presents with organ failure?
Pramod, before I start, on a Saturday evening, you're the only person suited and booted. That tells you why you are a professor and everybody else is not a professor. So I fully agree with you, Pramod. I'm really concerned because we always believe that when we do something, we fix the problem. But about 30 to 40% of the patients die before we even can do anything. And this patient is exceptionally sick with multi-organ failure. And I'm completely helpless on this patient. So if you ask me what you will do, apart from a consultation, ICU management, I will recommend some sort of enteral nutrition for this patient, like an NJ tube or a PEG tube, and I will just watch this patient and I can't do anything else.
So thank you. This is coming from a person who does drainage day in and day out. So I think participant must understand that not every patient will require some kind of drainage here. So organ failure is the key determinant of survival, as Sham has very rightly put in. And this could be early or late. Early organ failure is the one which is because of sterile necrosis, sterile pancreatitis. And late is because of sepsis or infected necrosis. And we published this paper a couple of years ago where we showed that how early and late organ failures affect the outcome. For example, if you have patients with acute pancreatitis, pancreatic inflammation, necrosis, this is what leads to SIRS and may lead to organ failure, what we call as primary organ failure. And some of these patients develop infected necrosis, which is what we are going to discuss later, and may also develop secondary organ failure. The reason I'm telling you this is that The outcome of the patients will depend not just on the collection, but many other factors, namely organ failure and whether the collection is infected or not. And this is the Dutch study published 2 years ago, which Shyam mentioned, that this is 639 patients, 219 patients that persistent organ failure. Mortality, 38%. Mind you, this is from a group of physicians and surgeons who treat acute pancreatitis, extensive experience they have. The mortality, 38%. And I'm really thankful to them for publishing this data, because otherwise people think the mortality is 5% or even less. And when we compared our mortality with the Dutch group and also another study from Spain, the mortality is around 40% or so, as we have seen across different studies. So early persistent organ failure is a sign of worry, major determinant of survival. And this is, by the way, at a time when necrosis and infection are either absent or evolving. So we need to be worried about these patients. So how do collections evolve and develop, and what can we do? Shyam has already shown you this. Just to reiterate that we can have acute fluid collections without necrosis, or acute necrotic collections, and which may remain sterile or infected, or we may have infection even in an earlier stage. And that's where we are worried about. And you can see these kinds of all sorts of collections here in these patients. So first week is when we say in the ICU, maximum support to the patient and start nutrition. In this patient, she started improving. There was no fever. CT scan was done, which showed this collection. So there is acute necrotizing pancreatitis with a collection, which is in the second week. Wall is not formed. So let me ask my panelists, Dr. Theo Anthony and Ben Moeller, would you do anything at this stage? Patient is improving. There is a necrotic collection. She's in second week of illness.
So I'm Anthony. So thank you for having me here to discuss this case. Certainly, if the patient is improving and if the CT scan shows such a small collection, definitely I will sit tight and wait. The collection is already still very small, and it's still very early, and there's not a wall, and it's not causing any symptoms, and it's not too sizable. So we'll sit tight. I will sit tight.
Dr. Ben Moeller.
Yes, thank you. Great case to introduce, I think, a very important consideration early on, which is the timing for intervention. And I think that currently there is consensus that, number one, if we do not have a mature wall, i.e. the patient has not had a fluid collection that is at least 4 weeks old, because we know it takes about 4 weeks for a mature wall to form, then we should hold off. So there's the so-called 4-week rule that we wait and we wait and observe. But having said that, I think a very important point here is that this patient actually is not that sick and is improving, because I think, and I believe Shyam showed this data from the University of Minnesota, which is a very important study, because despite the fact that it's not a randomized trial, so we need validation, but what that trial showed was that all patients who were sick, were septic, for example, had infected necroses, had multi-organ failure, that all of those patients improved when intervention was performed less than 4 weeks. So that 4-week rule only applies if the patient is stable or improving. Then you hold off. Okay. But if the patient's sick, then we should really actively discuss earlier intervention.
Thank you. So we'll come to that issue. Thank you, Ken, and I'm sorry you are very early morning for you. So thank you for joining. Good morning.
My pleasure.
Yeah. So obviously no intervention is required in this patient. Patient's improved and were discharged home. She doesn't have stones on ultrasound. So Shyam, what is the timing when you say we need to do etiological workup, i.e. EUS, because majority of patients will require that?
That's a hard one, Pramod. I don't have a straight answer. Usually I tell the patients after I don't want to do a EUS for the sake of doing an EUS in the hospital. If the patient is local, will come back. I will generally recommend a EUS after a 3-month window, because I can't see anything otherwise. I go in, there's so much inflammation and there's so much of debris and there's a little bit of necrosis. The parenchyma is not clear. I can't see anything. So I generally will prefer not to do anything within the first 3 months.
Okay, thank you. Vinay, I'll just bring it to you in. Would you do it after first attack of idiopathic acute pancreatitis? You want to wait for another attack? Vinay, your thoughts on that?
So I don't think it. Thanks, Pramod, first of all, for having us. Great questions. A very different kind of format. Very nice. So you want to find an etiology of recurrent acute pancreatitis. By definition, after first attack, it is not recurrent. But patients usually end up coming to us after the first attack also. And at least in our data, and I have seen your data also, there is a high incidence of chronicity at the beginning. So I do not say that don't do EUS after the first attack. Even after the first attack, we do the EUS.
Okay. So I think the consensus is we do it after 2 to 3 months, even after one attack of acute idiopathic pancreatitis. So now I come to the second case, 28-year-old female with acute pancreatitis. CT shows 50% necrosis with fluid collections, acute necrotic collections. She had early organ failure, admitted to ICU, improved, develops fever in the second week of illness. The classical presentation of infected pancreatic necrosis. She is on conservative treatment. NJ tube has been placed for nutrition. She receives combination antibiotics. Fever continues. CT done shows a large necrotic collections. There is no improvement. So when should we drain such a patient if we have suspected acute necrotic collections and we are still in the second and third week of illness? Vinay, your turn now.
Okay, so if the patient is showing signs of infection and patient is not clinically improving, I think we should drain. Maybe I will wait as much as possible, but if the sepsis is not improving, patient is not improving, I think we have to drain. And if it is established that you have a large fluid collection, the WBC counts and other evidence of SIRS is worsening, I would definitely drain.
Theo,
Now,
your thoughts on that?
When is like, I think subjective, depends on the patient's clinical condition.
Yeah, well, in general, I prefer to delay drainage as much as possible. Of course, these patients often will have a certain amount of fever. The patient may be in the ICU, and then the ICU guys will be calling you every day, asking you to do something. But I will try to delay as much as possible. Of course, timing is not a fixed rule. As we have seen just now, Shyam has quoted the study saying that if we drain earlier than 4 weeks, it's also possible. I think it really depends on the CT appearance. Some patients have early wall formations, 2 weeks, and I won't hesitate to drain if I require to drain it, as long as there's a wall seen in CT. Yeah.
So thank you. So the issue here is we are concentrating on endoscopic drainage.
No.
So we have to also think, even if the wall is not formed and patient has got suspected acute infected necrosis, can we do percutaneous drainage? We're not talking about peroral endoscopic drainage. And recently Pointer trial, I think, has finished. If I understand correctly, it has been presented and some preliminary data is out. Didn't show much difference if you drain it early or later. Ken, you were talking about this trial by Martin Freeman from Minnesota. If you have a patient in whom, and in Martin Freeman's series, patients had by and large encapsulated collections, even before 4 weeks. That is why they could do it. Now, what if the wall is not formed?
Yeah, so, and I think one point here is that in your case presentation, the patient had a contrast enhanced CT scan. And I think the better test to evaluate the necroses and the wall would be an MRI. So in these types of cases where earlier intervention is a consideration and we're not following the 4-week rule, because remember, this 4-week rule is pretty ingrained as a standard of care. So you just need to be aware of that is currently the consensus, that we wait 4 weeks. But if you are going to make an exception to that rule, then I think firstly, you should get an MRI. And then in terms of the evaluation of the wall, I think EUS would be complementary to the MRI. So you can get a good appreciation, in my opinion, with EUS in terms of the walled off component. Really what's critical, I mean, it's a pseudo wall, right? So it's not like you're going to see necessarily a thick rind, but you're looking at what the tissue around that walled off necroses or the organizing necroses looks like. And my primary concern is whether there's a lot of fluid around the pancreas or around this necroses, because that's where I get worried that we're going to, that we potentially will spread an infection to larger areas. Because even though the patient may be infected, now we're introducing other microbes. So we're weighing pros and cons. I wanted to make one important point about that Minnesota trial, something that surprised me, and that is the rationale for not intervening early also was that the complications from endoscopic intervention would be higher. And it turned out that the complications were not higher. In fact, they were lower. There was a higher rate of perforation when they waited 4 weeks, at least 4 weeks. And there were no perforations or complications from that early endoscopic intervention less than 4 weeks. So this concept that you need a mature wall so that you avoid complications of perforation didn't really hold up. And I think that's why the Pointer trial now was so important, because that's truly a randomized controlled trial, and that'll give us the answer. There's a second trial that I think is also pending that is randomizing patients. But the problem with the Pointer and this other trial is that, I think it's a Chinese trial, is that they are only selecting patients with infected necroses. And I actually want to know, even in non-infected necroses, would patients benefit actually if they're sick, right? But they're not infected, would they benefit from earlier intervention? Because too many of our patients, they sit in the ICU for weeks on end because we have to wait 4 weeks.
Right. So thank you. So the point here is that if you look at this patient, she continued to run fever, counts increased to 24,000. She has tachypnea. Her PaO2 FiO2 ratio was 280 in the first week, drops to 190. Now, how can you actually do MRI in such a patient? It's very difficult to do MRI, and she's in the machine for 45 minutes. It's not possible. So actually, most patients will have a CT done. And the same holds true for diagnostic EUS. You can't really do diagnostic EUS. So now, this is the kind of collection she has. I mean, I'm not sure. Sham, would you do endoscopic drainage here?
Well, I think
Sham, both of you.
they will usually, the IC will put a gun to your head, but looking at the CT scan, Pramod, this is not a good patient for an endoscopic drainage. I think I would prefer a book.
Right, Vinay?
Agreed, percutaneous.
Yeah, so the point I'm making here is that, we are in the second and third week of illness. Patient is septic. If you see here, the wall is formed, but the very different kind of collections. So I would agree with Ken when he says that Marty Freeman's trial in Minnesota showed that you can do early drainage, but in his series, 80% patients actually had well encapsulated collections in the lesser sac. So that's the point here. Now, so Theo, what would you do now? Sham said, no endoscopic drainage, patient is septic. Would you do anything now?
Well, from the CT scan, it looks like there are some gas inside the collection. I think for me, I think both endoscopic and percutaneous is okay. If we do a percutaneous drain, in general, the drain size is a bit smaller, so it might not drain very well. Of course, we can upsize it to like a surgical drainage, which we have done in the past. That's also an option. So for me, depending on the patient's condition, I would consider both actually.
Thank you. So you see, I'm forcing my all endoscopic friends to commit to a percutaneous drainage if they will. So she underwent a percutaneous drainage and discharged home after about 4 to 6 weeks. So this is what the consensus has been for a while, where you do conservative treatment initially first with percutaneous drainage, and if they require minimal invasive necrosectomy. And we showed in our paper earlier of 104 patients that mortality with conservative first approach rather than surgery first resulted in a better outcomes in these patients. And our systematic review and meta-analysis published many years ago showed of 314 patients that conservative first with percutaneous drainage resulted in 64% success, 70% patients required catheter drainage, necrosectomy in 26%, and mortality of 12%. So that brings me now to the third case, 25-year-old male, acute necrotizing pancreatitis, 5th week of illness, fever for 1 week, rising TLC. This is what all of you were looking for. Large collections, lesser sac, well-formed wall. Ken is ready with his hot axios. And this is what we're going to discuss. Endoscopic versus minimally invasive. Sham?
Endoscopic, Pramod.
Tell us about your MISA trial. People are eager to hear about that.
Well, Pramod, we have to, as you grow older, we take our own data with a tinge of salt. So we have shown that endoscopic drainage is comparable to minimally invasive surgery. What is the only difference is that the rate of fistula formation is lower with endoscopic. Patients likely will go home earlier, and the expense of that procedure is relatively cheaper compared to the surgical approach. Otherwise, surgery is very similar to endoscopy when performed minimally invasive.
Okay. Metal versus plastic. Ken?
Yeah, so I think there are multiple considerations. I'd like to know what this looks like on EUS. If it really is anechoic and homogeneous,
no, there is 40% necrosis, 40% necrosis.
Yeah, well then there'd be no question that I think LAMS would be the standard here. And that is best, that's actually defined now in the AGA statement, at least for the US endoscopists, as a standard of care to use a LAMS in preference to pigtails for patients with walled-off necroses, period. So that's a best practice guideline that's now established.
But the tension trial, the Dutch trial showed that they placed plastic stent, 2 7 French plastic stents, and compared with minimally invasive surgery, they showed equally good outcome with 2 7 French plastic stents.
Yes, well, so really what we need now with the tension trial is a trial that looks at LAMS versus maybe and it'd be interesting to compare the two approaches, because the one approach, I don't think it's so much the issue of plastic versus metal. The issue is irrigation versus no irrigation. So if you place 2 plastic stents and you place a nasocystic catheter for irrigation, continuous irrigation, that's different. That's a pretty aggressive treatment. And I think that actually will match the use of LAMS or be better even, potentially. But no one's looked at that. So irrigation is a very important part of this equation that nobody talks about. And in the US at least, really nobody's doing irrigation because it's just never became the standard here. But in Europe, for example, when I was with Nib Sahendra, we did nasocystic irrigation in all of our patients. And that's, I think, part of the reason why we had great results is we were every day, not only continuous irrigation, but we actually, and Whipple's there because he remembers those days, the endoscopist every day, we had these patients, inpatient, of course, actually, you know, aspirated 50 cc's, infused 50 cc's, aspirated, we did that every day. So that's a whole different approach. Irrigation. So that's what we need to discuss in the future. What is the role, if any, for irrigation in the LAMS era?
Okay. Vinay, what would you choose, metal or a plastic? I am willing to go with metal. In infected necrosis, 40% necrosis.
Total fan of metal. You know it. I don't place plastic stents. Last 3 years, I must have placed 2. The reason, Pramod, I think we are getting these results where metal and plastic are equivalent is because metal came with a promise of necrosectomy. And we do not have good equipments for necrosectomy right now. And so what you are doing is you put a large bore metal stent, the water comes out, but the rest of the thing takes its own sweet time to heal. So you have just increased the diameter, but you haven't utilized the full potential of that metal stent. That is what I feel. So hopefully if we have something better for doing necrosectomies, and we can do immediate necrosectomies, fast necrosectomies, and clean the whole thing, probably these trials will show a difference.
I agree. So I think most people have now shifted to a metal stent, particularly if you have more than 30% necrosis, and especially if there is infected necrosis. What we find is the moment you put only plastic stents and a lot of necrotic debris and infected collection, it tends to actually close within a few days. And then there is a problem. You have to go in again and dilate the tract and go inside and do necrosectomy. And I don't mind doing that. If you have planned it, it's okay. But I think the advantage of a metalist remains patent for at least a week, and you can easily go in when required. Suyatio, I will come to you, Dr. Anthony, here, that in terms of technique of putting in a metal stent, your choice now is hot Axios, or you are okay with any other metal stent that are available, given the cost, the time, and technique?
Yeah, so
like this. Which one would you prefer?
Yeah, so I think Axios worked, Spexis worked, Nagi works, and nowadays Spexis has also a hot version. So the direct puncture technique is not only restricted to Axios. I think Nagi stent also works well, but it tends to migrate a little bit more often, especially during necrosectomy. And the Nagi stent, the cost of Nagi stent is quite similar to Spexis. So nowadays we're using more and more hot Spexis because it's about half the price of hot Axios. And for the trainees, we are giving all the trainees these procedures. It makes the teaching and learning much more easier. So yeah, currently we are using a hot Spexis.
Okay, good. Ken, I would ask you, when you open these hot Axios, the proximal end, do you open it inside the channel, or you want to see the stent open outside the scope? Which one do you prefer? I know your preference, but I want to ask you.
Well, actually, I've always done it one way and only one way, which is to deploy it inside of the channel. And then, so I keep my eye actually on the EUS image until I've fully deployed the stent, whereby the distal flange, of course, I see on ultrasound in the cavity, and the proximal flange is in the working channel. Then I switch to the endoscopic view and I push out the proximal flange, and I watch that flange open up in the lumen. And you have to back off, of course, from the wall a little bit, and you make a slight turn to the right as you're pushing it out. So that's always worked beautifully for me. And the only reason why it was that black marker was placed on there is just really as a backup, just in case for some reason, you know, you want to use endoscopic guidance rather than do this under what I call EUS guidance. Of course, it's a hybrid guidance, right? Because in the end, you do see the proximal flange deploy.
Is there a risk that it might entangle in the elevator?
It's never happened to me.
Okay.
I'd love to hear from the others, but it's worked flawlessly for me in terms of its deployment. Again, I can just emphasize that you need to be sure, of course, that the distal flange is really snugged up against the wall, because the risk of this method is that you could, of course, deploy the whole lambs inside of the cavity. So as long as you are sure that on EUS, the distal flange is up against the wall, then I think it's pretty flawless, and it's always worked for me.
Thank you. Sham, I want to ask you one question about this issue. The patient has respiratory failure, right? Grade 3. She is on high flow oxygen, sometimes an IV. You have to do endoscopy procedure. Do you do under GA with intubation or conscious sedation?
So
And what is the risk of patient being on a ventilator for a day or so? That's a common concern.
Yeah, but all large fluid collections promote for the risk of aspiration is also a medico-legal risk for us. Our anesthesiologists probably dictate how we do the procedure. So they'll tell you it's a big collection. Is there a small risk of aspiration? Even if you tell them there's a 5% risk, they all go under GA. That's it. And after the procedure, more than likely, they will be extubated. And if they're not extubated, they go to the ICU until they will require extubation. So for all index sessions, necrosectomies, everything, it's done only under general anesthesia.
Right. So that's the general practice. But have you noticed that sometimes patients require ventilation for at least a day because they can't really, if patient is septic to begin with and is grade 2 or 3 failure, they cannot extubate just after the procedure on table.
Well, sometimes we get same day transfers from other hospitals for the procedure and sent back. So all drainages, we tell them, listen, there's no guarantee what is going to happen. And I think that is where informed consent comes. Before even you do the procedure, to talk to the family and the patient and explain, listen, very likely you'll go under on a breathing machine. There's a good chance that you may not come out of the breathing machine after the procedure, and to prime them for the outcome. The thing is to over-promise and under-deliver. So we always do it with GA and it happens.
So the reason I wanted to emphasize this point is that all the gastroenterologists and endoscopists should think they are doing a surgical procedure. They are not doing just another diagnostic endoscopic procedure. So I think this is a purely surgical procedure done endoscopically. It requires proper preoperative anesthesia workup. It requires proper monitoring. Patient may be in ICU on a ventilator for at least a day. So I think that has to be conveyed very clearly to the relatives and others, because people think, no, you are doing endoscopy, so it's not a big deal. So I think this is important, because surgically when they operate, many times patient is not extubated for 24 to 48 hours electively. So I think that's an important point. So coming to another case 4, now you have done your paroral. This is a patient, 28-year-old male, respiratory failure, renal failure, first week, 4th week fever, rising TLC, procast high, no improved antibiotics, and this is the CT. Like the first case. Vinay, what you do here? You wanted this.
This is done. The other one
you get this, or you get this.
Can we now remove the photos from here? I can't see the CT. Our photos are coming in front of the CT.
You can remove that on your screen.
You can do it. How?
The photos you can make smaller.
Got it.
Yeah.
So what, you want me to drain this endoscopically?
I'm asking you, would you do that? If there's fluid all around.
Yeah.
There is infected necrosis.
Yes. So probably you can drain part of it endoscopically, but it will need more than endoscopy. This is, of course, endoscopy. No question about it.
But often the situation is like this.
Yeah.
So you end up doing percutaneous drainage. The problem is with percutaneous drainage, what do? There is infected necrosis. You got a lot of necrotic debris there. So what would you do here?
How about, of course, we end up combining the two sometimes. You start with endoscopy, the patient doesn't improve, and then you end up with percutaneous drainage. That can also, but here percutaneous, I feel, will be necessary, the last CT that you showed.
Right. So what we do is, in this situation, that we dilate this percutaneous tract and do percutaneous endoscopic necrosectomy. Sham was also referring to that. And we gradually dilate from a 16 French. Nowadays, actually, we put 18 to 20 French up front, percutaneous catheter, and lavage it with an ultra thin endoscope, which is only about 5.5 millimeters. Go inside, lavage the cavity, take out the pus, patient improves, dilate it to then about 28 to 30 French, and go with your regular endoscope, and then you can do necrosectomy. This we have done actually at the bedside of the patient. Multiple ports are there. You can see a large tube here. This is an ultra thin scope going in from a percutaneous tract to lavage. And many of times these patients continue to be septic. We dilate with a CRE balloon, go inside now with a regular endoscope, and do what you do per oral endoscopic necrosectomy and lavage. And this procedure we find is well tolerated by the patients because you don't need to do GA here. You can do it under constant sedation. And the other advantage is you can tailor it to the patient's condition. We can do it for 10 minutes. I can do it for 30 minutes. The max I've done is for about 45 minutes, depending how the patient tolerates that. And afterwards, you find that the cavity can be cleaned. So in some patients, it may take at least 3 to 4 sessions. In some patients, it is easier. You can complete the whole thing in 1 to 2 sessions. So this is something that we have found very useful in laterally extended collections, large collections, multiple collections. And you can see, you really can't say whether you are doing it percutaneously or through the percutaneous or per oral route here. So this is the kind of necrotic debris that can remove, and the cavity looks like this. This is an experience of 15 patients we published many years ago, and subsequently we extended to other patients. See a large collection here. 2 drains have been put, one here, and the kind of debris that you can see when you put your endoscope inside, large collections, pus there. So what we have now started doing in some of these patients is to put a esophageal metal stent like this percutaneously, and then do necrosectomy like you do per oral. And then you can clean up the cavity here. So this is same patient, pre-drainage and post-drainage, the entire collection is gone. So in our latest series of 177 patients with necrotizing pancreatitis, we found with percutaneous step-up approach about 80% success rate. Ken, what would you do in a situation like this? Do you agree with this approach, or any suggestions?
Yeah, absolutely. I agree. I think my only regret as I've seen this field evolve, there's certainly a benefit to endoscopists becoming more aggressive and being able to manage what has historically been managed by our interventional radiologists. The downside is that our interventional radiologists are losing their skills in performing the percutaneous drainage. And back when this was first developed by Freeney in Seattle, they did necrosectomy and they knew how to do necrosectomy. And I think the key here is the necrosectomy. So if you just stick some percutaneous drains and your radiologist doesn't know how to manage necroses, then I don't think you're helping the patient. So the assumption is that you have radiologists who know how to perform percutaneous necrosectomy, or they have someone like you who knows how to work with the radiologist and go percutaneously and do necrosectomy. That works as well. But that's so important, is the emphasis on the necrosectomy. My other comment, though, is that if you look at all of the trials comparing percutaneous with endoscopic, the one common denominator is that when you do percutaneous, you are unfortunately too often left with fistulae later. And the Miser trial showed that, for example. Now, if I'm a patient, I don't want to have that risk of having a fistula that's draining from my abdomen for the rest of my life that doesn't close. So that's just another consideration when we weigh the pros and cons. But clearly for your case, I mean, that's not amenable to endoscopic treatment, really. So it's off the table. It's really a question of percutaneous versus VARD, which is VARD has now become percutaneous, essentially. It's just by surgeon, not the interventional radiologists. Can I take this opportunity to just make just a little comment? So firstly, let me just say, I've absolutely no conflict of interest here because I receive no royalty or any compensation for Axios, but I'm a proud parent of the Axios. However, I just noticed that Anthony Teo mentioned in terms of preference of lambs. So I think the Spaxis, which is a beautiful stent, I love it, and it's not available in the US yet, so I really haven't had a chance to use it, sadly. But if he's saying that it's being used more often now, I'm all for that, but it's also Anthony that so beautifully in his ex vivo trial that I participated also in, that showed that the lumen opposing force was far superior, significantly superior when you use Axios compared to Spaxis, and much better than even compared to the Nagi, which is really a nice stent, but it wasn't designed actually for for as a lumen opposing metal stent. So I just want to emphasize that if you want to have good lumen apposition, so for example, to do necrosectomy, you want lumen apposition, right? You don't want your stent pulling out every time you go in and out to do your necrosectomy. Well, then you might want to consider what currently is more expensive, I realize, but it has superior lumen opposing force.
Thank you. So we move on. So I just wanted to show some cases to say that peroral endoscopic drainage and necrosectomy may not be suitable for everyone with infected necrosis. The location, the number and timing of fluid collections and organ failure determines outcome. And that was brought out by Shyam in his talk very nicely. The other thing I wanted to show is I've taken from Shyam's paper here. Look, the number of patients they screened was 168. They ended up enrolling 66 patients. So, only about a third of patients are suitable for such drainage peroral endoscopically. And also in the Dutch trial, they screened 418 patients with necrotizing pancreatitis. Only 98 were included. So the point is, when I show you a large collection in the lesser sac, you go in and put a hot Axios or Spaxis or whichever stent, you're fine, but not in everybody. And that's an important point. So brings me to the last case, 35-year-old male presented with 12 weeks of illness, abdominal pain, distension, CT and ultrasound show large pseudocyst. The point I want to make here for the audience is that when you think it is pseudocyst, it may not be pseudocyst, it may be a Waldeck necrosis, so you have to be careful. This is purely a pseudocyst, and Ken was mentioning earlier that MRI, a T2 weight image MRI is very good to show how much is the debris. So there is no debris here. This is a pure cyst here. So the patient has a pseudocyst here. Shyam, you compared this endoscopy versus laparoscopy. If it is non-infected, this is stable patient, sterile collection, two issues again, endoscopy versus laparoscopy.
I think it depends on the place, Pramod. I think in the United States, it's definitely endoscopic drainage if you're because money is not an issue. I think if I'm doing the same procedure in India, I learned from my experiences that the surgeons, the lumen opposing stent is so expensive, the surgeons can give a very comparable outcome with a lap approach, lap cystectomy, unless you want to place a plastic.
And Vinay, here would you like to place a plastic or a metal stent if it is a pseudocyst?
I always place metal stents. I am biased, I know, the literature shows otherwise. But I believe my patient needs fast and efficient drainage.
No, but give us a reason why you want to place a metal stent in a pseudocyst.
Because it's over in 3 weeks.
In terms of what?
Complete drainage, complete clearance, cavity is healthy, granulation tissue, take out the stent, patient is happy. And my patient can afford a metal stent. So I know what the literature says, but.
Okay, but I think the message here is individual preference is fine, but Shyam has shown, other studies have shown that for pseudocyst, I think plastic stent is as good. Fine. Anthony, do you have any other differing opinion on that? Pseudocyst, no necrosis, stable patients, 3 months down the line?
No, it's fine. Plastic stent is fine. I know.
Anthony, you have to unmute yourself. Yes.
Yeah. So I think plastic stent will work. If you do choose to place a plastic stent, I will place a couple because they tend to, there's a high chance of obstructing, causing infections. And for patients, sometimes if we put out they are living far away, they don't have easy access to medical attention. You may also want to put a plastic stent because you tend to leave them in for longer, and you sort of don't want to have to worry about complication of metal stents happening. So I think it works.
Okay. So we actually did a comparative randomized trial of endoscopic versus laparoscopic drainage in pseudocyst and Waldorf necrosis. And we found that plastic stents do as well as laparoscopic drainage, which of course provides you about 6 centimeter stoma. In this study, we found that overall about 50% of patients developed infection after drainage with a plastic stent, requiring a scheduled re-endoscopic intervention, which was planned a priori. So we found that even plastic stents for stable patients, no infection, they do as well as laparoscopic surgery. And the advantage of laparoscopy is that patient has associated gallbladder stones, then we now prefer to do laparoscopic drainage plus cholecystectomy in the same sitting.
So Pramod, can I ask you a question?
Yes, please.
In this study, did you pseudocyst completely collapsed and it was healthy granulation tissue? Surgery, of course, it is immediate, right? They have done laparoscopic cystogastrostomy and everything in that 48 hours or whatever, 72 hours. With plastic stent, how much time does it take for the cavity to fully empty out?
So thank you, Vinay, for this question. So what we have seen is we do actually serial ultrasound in these patients for at least about a week. So you do see ultrasound next day, then 3 days and 7 days. We found majority of patients do very well and the cavity collapses, except if they develop fever. Now in some patients, they develop fever. Then we go in on day 3, day 5, depending on the situation, and dilate the tract and do lavage and necrosectomy. So this is the one last question here, and I will ask you, Sham, the concern that you have in a patient like this, and you mentioned in your talk, is disconnected pancreatic duct syndrome. Is there a need for ERCP? Sham first, then Anthony, and then others.
Well, if you don't have a good MRI in your facility, then you need ERCP. I mean, we don't have good MRI, you'll be very surprised. So it's always iffy.
No.
If you can do a MRI with secretin, Pramod, awesome.
No, I'm saying before you drain. So you have a large collection. MRI won't show you anything. You have drained endoscopically. Would you do ERCP in the same sitting or no, as was promoted earlier? We don't do it.
We don't do it either. I think the successful
I
ERCP.
think that's an important point. Anthony, would you do ERCP in the same sitting?
No.
Okay. Ken, would you do ERCP?
I honestly can't remember the last time I did an ERCP in a patient with one.
So thank you. So this is the latest data published from Dr. Reddy's group. Sandeep Laktekia published that in Gut last year. 274 patients underwent EUS drainage. 219 had ERCP later. 74% were found to have DPDS. ERCP in standing could be done only in 12%, mind you, because there is a stricture, there is a disconnection. So there is no point trying to do ERCP in these patients. And fortunately, the recurrence of collection was only in 13%. So I think often it is overemphasized that they will develop disconnected duct syndrome. But we have also seen now in a series of 100 patients that majority of patients remain asymptomatic, even if they have DPDS. So ladies and gentlemen, I'd like to conclude by saying that acute fluid collections without necrosis resolve. We don't need to do anything for them. Acute collections with necrosis, it is the necrosis which determines the outcome. And if they develop infection, the current treatment is conservative, followed by either percutaneous or endoscopic per oral drainage, depending on the location. And some patients may require minimally invasive necrosectomy, whether you do it transoral or you do transperitoneal or transcutaneous. That depends on the expertise and the collection. And once you have symptomatic Waldorf necrosis, stable patients, we can do either endoscopic or what we prefer, laparoscopic, if they have associated gallbladder stones. So I'd like to thank all the panelists, star panelists I have. It was a pleasure discussing with you. and we can have some questions if we have. People, over to you, and Rajesh and others, and Dr. Rajkumar, Dr. Naresh Bhatt.
Pramod, it was a wonderful discussion. Can I have a question?
Yeah, please.
Pramod, when you do direct endoscopic necrosectomy and you have an extensive necrosis, what are the risks that you will create a fistula, organ fistula, like a duodenal or a colonic fistula in these situations?
So first of all, when you do percutaneous necrosectomy, we haven't actually seen bowel fistula here, because you have to be very careful when you do necrosectomy. You have to take out only the loose necrotic debris. There's no point trying to, forcibly take out necrotic debris. That's one. The concern here is, will they develop percutaneous fistula, a pancreatic fistula? Now, we haven't seen it in most of our patients. They do very well. So what we do is we downsize the catheter size from a 30 French to down to 16 French. And after they have improved, we disconnect the bag and convert it to a colostomy bag. So once you take out the effect of gravity and you downsize the catheter size, there is no problem as far as pancreatic fistula is concerned.
My second question is, when I put a metal stent, I found that second day or third day, the whole necrosis has come in and obstructed the diameter of the metal stent itself. Now, if we put plastic stent, how do we expect that they are not going to get blocked when such a large diameter gets blocked easily with the necrotic debris?
So you see, the problem occurs in metal stent, not in plastic stents. This problem of necrotic debris obstructing the lumen is in the metal stent. And that is why many people actually prefer putting in a plastic stent through the metal stent to prevent this. In plastic stent, the problem is the stoma closes. And once the stoma closes, they develop infection or there is insufficient drainage. So that's the problem.
A couple of questions online, Pramod.
Yes.
One, I think Shyam can take on. Is there a role of very aggressive things for a necrosectomy? Someone has asked whether you use an endorotor for a necrosectomy.
I mean, I think there's been a recent study that shows that the endorotor is useful, but you have to remember the endorotor actually was made for polypectomy. After you remove a sessile polyp, they were worried about some fragments. Therefore, the endorotor was made. It didn't work out there. Then they figured out what to do with this endorotor. And it so happened they decided, let's do it for necrosectomy, because nothing works for necrosectomy. So I would, so this is the background of the endorotor. I have, they've been aggressively pushing. I don't know. Couple of things is this. I think Ken indirectly brought about this, and Pramod is talking. I think after you place a stent, the stent is only the first step in treatment. There are multiple things that should happen afterwards. One of the things we do is we used to look very happily at lamps placement. 5 minutes in and out, plastic stent, 40 minutes. As you grow older, you realize that is such a naive thing to do. After you place a stent, it's important to take the time and then put an ERCT cannula inside and irrigate aggressively. And aggressively irrigate for it could be 20 minutes, 25 minutes. The consistency of the fluid going in should be the same thing that comes out. If the patient fortunately has a percutaneous drain and they are in the same cavity, you use the drain for irrigation, and you want to make sure you get good reflux into the stomach. And if you take the time to irrigate at the index session, the treatment outcomes definitely is much better. Then you will have less problem of what Rajkumar is saying about a stent getting occluded with a big debris. It can still happen, but usually less. Another thing is when a percutaneous drain is placed, it's important to communicate to the radiologist. It's not enough to just say, please get me a big drain. It's important to tell them, please avoid placing the drain if possible through the intercostal cartilages. Because if they place it through a cartilage, then what Pramod is describing of performing a percutaneous endoscopic necrosectomy can be excruciatingly painful for the patient. So it has to be done in collaboration with them. Yeah. And finally, I think there's nothing too aggressive. You have to be careful. If you have a complication, then the whole purpose of minimally invasive becomes obsolete. So you can debride as much as you want, but you can use hydrogen peroxide. You must irrigate aggressively, and irrigation and the importance of irrigation cannot be understated.
Can you spell out the hydrogen peroxide protocol that you
3%?
use?
It comes in 3%. We mix it 25% peroxide, 75% saline through a huge or a distilled water through the water button, through the water canister. Attach it to the scope, and you just use the whole thing.
Shyam, we have actually stopped using hydrogen peroxide because 2 of our patients developed peritoneism,
So
One
that
was to be operated.
so yep, that's a catch there, Pramod.
Yeah.
The catch is this: if you've got a collection that is close to the stomach and it's a big collection, and it is very well opposed to a large area, leakage doesn't happen. When this problem happens, Pramod, is you got a 9 centimeter collection approximating with the stomach over a 3 centimeter area, and you're irrigating, it leaks out. And when it leaks out and they wake up, they are screaming like crazy. And you do a CT scan, air bubbles are seen in the abdomen, and your radiologist is telling you this is perforation. He doesn't know it's hydrogen peroxide, and they have to go for a peritoneal lavage. Well taken. So I think if the area of approximation is large, it's less likely to happen. The advantage of a peroxide, Pramod, is what it does is there's no evidence again. When you go back for a subsequent intervention, it makes this the material that's floating all over into a nice big mushy thing to take out easily. That's pretty much it.
One small
sorry,
question, excuse me.
Dr. Vipul, Dr.
Hey,
Vipul,
last
I
question,
think
Rajesh, one last very important question we need to ask all our experts here. In a disconnected duct syndrome, if you have a tail duct, how many of you intervene in that duct, EUS guided? How many of you leave just a stent indefinitely to prevent recurrence of pancreatic fluid collection?
I mean, I can take it first. I think, as you know, Gopal, intervening in a pancreatic duct is probably the most difficult EUS guided procedure. The simplest thing is to just leave a stent. It is not the perfect mechanism. Hope for the best. There is some data to say it works. We are trying to avoid a pancreatic duct as much as we can, particularly in a disconnected duct, because with so much collateral, generally it's only a 60% success rate. It's a bloody mess.
Thank you very much, all of you, all the panelists, and Dr. Garg. Over to Dr. Rajesh Puri, please,
so.
and all
I would-
our chairpersons,
I
please.
would like to thank all chairpersons, moderator, and the panelists for the great discussion. And this is the last session, and we'll start next proceeding tomorrow morning at 8:40. And I'm thankful to everyone, Dr. Kenneth Binmoller, Dr. Shyam, Dr. Anthony, Dr. Vinay, Dr. Naresh Bhatt, Dr. Vipul, and especially to Dr. Pramod Garg for making the discussion excellent. Thank you. Good night.
Thank you
and
all
good
very
morning.
much. Have a good day.
Namaskar.
Bye-bye.
Thank you.